Okay, let's make sure everything's good and we'll get going. All right. Hello. Hello, everyone. Let's take a look. Let's see how it's going. Let's see if our live broadcast is showing up or is it not showing up? I don't know. All right. I think we're here. I think the broadcast is running. So let me just share it on Twitter and we'll get going. So sorry for the bit of a delay. Sometimes this happens. Just a little behind today. So very sorry. All right. Let's just get it on Twitter and then we will get going. Okay. All right. So we have now shared it. I think we are. I think we're good to go. I think we're live. Awesome. Oh boy, there's just so much to discuss today. It's going to be an interesting chat today. We've got really genuinely a lot on the docket, so we'll see how it goes. So, good afternoon, good morning, good evening, whoever you are, wherever you are. I am Dr. Patrick Lockwood. For the purpose of this podcast, I am just Patrick, so please don't sue me, etc., etc. So, this is UnShrink Me, and if you are brand new to the podcast, this is a weekly show live streamed on YouTube, so please like, share, and subscribe. But the purpose of UnShrink Me, in case you're brand new, is to share, discuss, explore mental health concepts, clinical psychology, psychiatry, therapy, ideas, trends, topics, and make sure that the consumer is protected. Because the reason I started this podcast is to protect the consumer, the people that are seeking out therapy, psychiatry, etc. Because what I have observed in my career so far is that many well-meaning people hurt patients. Many people are ignorant about things they don't understand. Many clinicians are very thoughtful, smart people who also are, let's say, misdirected by their faculty, their supervisors, society, professional organizations like the American Psychological Association. So the goal of this podcast really genuinely is to protect society, to protect the consumers, to share information and perspectives that might help you make more informed decisions about your choices for mental health care, be it psychiatry, psychology, therapy, or even coaching. I don't recommend coaching, but if you do, I want you to be as well informed as humanly possible when I see something show up about that. So that's the spirit of UnShrink Me. That's why I call it UnShrink Me, because shrink is this pejorative for hacks and gurus. And I'm, let's say, anti-guru, because I myself am not a guru. And the spirit of this podcast is not to make me look like a guru, because I'm clearly not. So welcome everyone. We have so many topics. We're going to talk about porn today. We're going to talk about PSSD, post-SSRI sexual dysfunction. We're going to talk about what real therapy is today, because I think real therapy is one of those trendy topics that always shows up on ye old Twitter. And we're going to talk about harm reduction a little bit as well, because harm reduction is also one of those trendy things online. And as always, I am not yet at least sponsored by Celsius. So, but thank goodness for it. It's great stuff. All right. So first things first, we are going to discuss, let's start by talking about where to begin. So many interesting, fun places to begin. Well, first, let's talk about SSRIs and PSSD. So this is an easier, simpler one, but I think it's a tough one. And so let me just tweet something real quick, because the account that asked me to talk about this surely would like to know that I'm talking about this. Okay. So I just reposted something from a Twitter account called PSSD Network, which is the Post SSRI Sexual Dysfunction Network, and their handle is at PSSD NETWORK. And so there was a recent New York Times article that came out discussing the real adverse effects of taking SSRIs. SSRIs, selective serotonin reuptake inhibitors, are a class of antidepressants that supposedly serve the function of stabilizing the amount and frequency of distribution of serotonin in the synaptic cleft. It does way more than that, in all honesty, but that's the spirit of what they're supposed to do. And so most of you probably know that SSRIs have this well understood sexual dysfunction side effect or adverse effect. And so something that many people don't know, which I believe is why this New York Times article came out, is that for many people, the sexual dysfunction they experience while they're taking SSRIs will persist after they've completely ceased taking them, and it's all out of their system. So something everyone needs to understand and know is that SSRIs are commonly prescribed for anxiety disorders, depression disorders, and related conditions. However, these difficulties with depression and anxiety, are not fully managed by SSRIs alone usually. And so most people usually need some combination of SSRIs plus psychotherapy, lifestyle change, exercise, et cetera, et cetera. Now, the PSSD network, the account that asked me to talk about this, has this neat little infographic that I just retweeted. And I'm just going to read some of it out loud in case those of you who are taking these medications are not aware. Maybe you should be aware, because I think that it's generally an accurate infographic. So they have this infographic they posted on, I think, 6/19 of 2023. And it's split into two parts. It says, what is PSSD? And then what isn't PSSD? So post SSRI sexual dysfunction. That's PSSD. So post SSRI sexual dysfunction includes symptoms such as genital anesthesia or numbness, where your genitals before SSRIs were more sensitive to touch and other types of stimulation and are now less sensitive to touch and stimulation. Another classic adverse effect that shows up in PSSD is emotional blunting. So for those of you who may not be super aware, one of the ways that we experience sexual arousal is through emotional arousal. So part of our sexual arousal template, if you want to call it that, for all mammals, includes general emotional experiences. So many of the problems that people experience both while they're taking SSRIs and when they've also gotten off of them is that emotional blunting that can happen because of SSRIs can also interfere with sexual interest and sexual arousal, because we have to be capable of being interested and emotionally engaged in order to be sexually aroused as well. So people will mistakenly believe that they just aren't interested in sex, when in reality it's just they're experiencing emotional blunting that is causing them to be less interested in a sexual partner, a romantic partner, etc. And in some very rare cases, people experience, as the infographic says here, total loss of libido. Now that's statistically more rare, but it does happen in some cases. So the spectrum of impairment from PSSD, post-SSRI sexual dysfunction, is a spectrum. So some people will have permanent damage. Other people will have mild to moderate damage that lasts for a very brief period of time. And some people are in between, where it will last a very long time, maybe years or even a decade. So what PSSD, post-SSRI sexual dysfunction, is not specifically. It is not low sexual arousal. So just because you have a lower sex drive doesn't mean you're experiencing an adverse effect from SSRIs, for instance. And usually, if you stop a medication and your sex drive returns to normal, whatever that is for you, then genuinely speaking, that's not PSSD, right? And so I want to make sure it's clear, and I'm just a psychologist. I teach psychopharmacology, etc. So within that scope of practice, I'm just telling you that a lot of people will experience mild versions of sexual dysfunction when they're taking SSRIs, and it will disappear. And that's great. And that's true for a lot of people that take SSRIs and similar medications. However, this unique syndrome called PSSD, which was talked about in the New York Times, that is not something that just like goes away, right? That's a syndrome that can last months, if not even years. And so I want everyone to be clear that all psychiatric medications carry a risk. And there are no solutions, there are only trade offs. So you cannot have a perfect, easy solution for depression, PTSD, anxiety, or bipolar. There are no easy, simple treatments or solutions. There are only trade offs that we have to make. And so be clear that if you are taking a medication, it's not a death sentence. It might be risky for some people and less risky for others. It's a spectrum. And so be clear that you are at risk of some post-SSRI sexual dysfunction if you're taking SSRIs. However, one of the best ways to prevent that is by being very aware of your sexual arousal currently and tracking it and monitoring it over time and talking to your doctor about it as it's happening. Because if you don't talk to your providers about what you're experiencing, you're not going to get any help. You're not going to make medication changes or dose changes. So please be very clear that this is a manageable and even preventable problem for many people if you're communicating regularly and consistently with your provider. I hope that makes sense to everybody. You know what I mean? So thank you. I hope that makes sense to everyone. And just a second. Okay. All right, so that's enough about PSSD. I hope that's clear. It's a real thing, and it definitely needs to be addressed because some people are not going to get it. They really, really aren't. And many people experience a numbing, and that's a huge problem. A Career Flex, one of my friends and colleagues just chimed in on the YouTube. He said, SSRIs are terrible for me, numbing. Yeah, and numbing is an unintended consequence of taking SSRIs, right? So for many people, they will experience some emotional blunting or numbing because when you're taking an SSRI, you're not trying to enhance your mood. You're trying to stabilize the frequency and prevalence of serotonin being available. So you're creating a consistent availability, which is unnatural, by the way, because your brain produces different amounts of serotonin, etc., chemicals in response to external stimuli, stress, internal stimuli, so on and so forth. You know, so that's a very common adverse effect. Please talk to your doctor. By the way, very glad you're here, sir. Good to see you here. All right, moving right along. Next up on the list. So I think it's time we talk about porn. I think it's time we had the conversation about porn. So let's talk about it because I've had this conversation publicly a number of times, and I most recently had this conversation with some of my colleagues, including President Company. And so I really want to talk about here this really important issue related to what pornography is and isn't, how it affects the brain, what pornography use can do, good, bad, or otherwise, etc. Career Flex says, I got here late, so apologies if they've already been addressed. Did the chemical imbalance theory of depression get debunked? Yeah. I mean, there is no perfect chemical signature for depression. We have no clue what depression looks like in the brain in a real, reliable way across ages, genders, and cultures. We have no clue. I hope you're having fun in elk camp, and I hope that I hope you get a good elk. I would wish I could taste some of your elk meat. No pun intended. Yeah, there is no chemical imbalance theory of depression. Everyone knows it's not real. Everyone knows that antidepressants can help, but they're not super precision molecules. So we have to be careful about how we prescribe them and what our expectations actually are about SSRIs and related medications. But let's talk about porn. I think it's time to talk about porn because why not? What else should we talk about in this Saturday? Let's talk about porn. Porn's great. So, um, uh, I feel very interested in talking about this because this is uh, this is a huge deal, and I'm going to retweet something. Your elk meat, yes, I definitely want to taste your elk meat. Um, let's talk about this. This will be fun. Okay, so let's talk about porn because I think this is going to be important for everyone. So, just so everyone knows, and I can link this video later on, but I already produced a YouTube video years ago that looked at the research on the harms and what pornography is and what so called porn addiction is. So I tried to go through the available evidence like 5 or 6 years ago, something like that. And so you can go find that video. I'll post it in the caption when we're done here. But I don't want to be redundant for that video. But I want to specifically talk about a tweet that I posted a couple of days ago because I think that it's really important that the public is clear about words like addiction and compulsion and things like this. And I did talk about this with my friends on the Men's Mental Health podcast a couple of weeks ago or a month ago, which was a great time. They're awesome guys. Ryan McRogers, Jake Whiskerchin, Jonathan, I forgot Jonathan's last name, Jonathan Cogburn, and God, and then the other immature Jake, as I recall. All of our friends, we talked about it, and I think it was a great conversation. It was a good start to the conversation. So let's talk about it. So I just reposted this, and I want to make sure everyone's clear about my intention here. So for everyone who is watching and listening, either currently or in the future, etc., I want to say this as loudly and clearly as possible. I do not believe that pornography is inherently good or inherently bad. I believe that pornography is no different than music, than caffeine, and than all sorts of other substances we can have an active relationship with. So pornography is a stimulus that we can have a relationship with. And the question for me is, what kind of relationship are we having with this? Because caffeine is an artificial way of being energized. Music is an artificial way of having emotional experiences. Unless you're like singing with people, then it's less artificial, right? And so pornography is an artificial way of being sexually aroused, etc. So that is my down the middle, like centrist view of pornography. I don't think it's inherently good. I don't think people should be using it all the time. I don't think it's inherently bad. I don't think people shouldn't be using it all the time. It is my genuine belief that pornography is a stimulus that people can have very pathological relationships with or more neutral relationships with on the whole. And so what I genuinely believe is that there are kind of three categories of pornography users. And I think the research basically bears this out, but don't quote me on this, right? So in my experience, both clinically and in looking at the research, I believe I've seen three types of pornography users. Maybe there are more, but this is what I currently see. So category one, and this is in no special order. It's not like hierarchical. It's not like best or worst. So category one are people who occasionally will use pornography and will not use it compulsively. They'll use it like once in a while, maybe for, 5 minutes or a couple, however long, whatever. Excuse me. And they'll use it for a specific purpose to be aroused and get off and be done. And then they'll go about their day and they won't think about it ever again until the next time they have no sexual partner or whatever it is. And maybe they'll use porn inconsistently or maybe somewhat consistently, but it's not in a pattern that's rigid. It's not compulsive. It's not, euphoric or whatever other than for the 5 minutes that they're experiencing it. They're not anticipating it. They're not, I can't wait to get off. They're not obsessing about it. And that's probably, in my estimation, it's just an estimation, that category one group of people, here's Willow, that category one group of people is probably the average person who uses pornography. So that's category one group of people who uses pornography. Category two are people who have a relationship to pornography where they have habits and rituals, they have expectations, they have their favorites, etc. And this group of people who has a relationship to pornography is starting to use it in an avoidant kind of manner, but it may or may not be compulsive or problematic consistently. So this is category 2, that are using it in an avoidant way and are using it to manage an unmet relational need, but it may or may not be compulsive and problematic consistently. So that's category 2. So you can call that like problematic porn use if you want. Category 1, ordinary porn use. Transitory, not consistent, not particularly problematic. Category 2 of pornography use. Maybe 20% of the people who use porn. Maybe, I don't know. These are people that use it in a patterned way. They're using it to fulfill relational needs without actually having real intimate relationships and sexual relationships with people. And they're probably avoiding attachment issues, shame, trauma, religious stuff, whatever it is. And this is maybe 20% of people who use porn, something like that. And then category 3 of people who use pornography are the extremely problematic types, the people that have a problem with porn for real that really need help, right? In my opinion, my opinion, right? Not the research, not some official body, just me. So category 3 probably represents 1 to 5% of people who use porn, especially regularly. So category 3 is a special group of people. So depending upon the research that you read, you'll find different terms and definitions. So in some literatures, you'll see people use the phrase compulsive sexuality. And some literatures, you'll see problematic pornography use. And other literatures, you'll see porn addiction or sex addiction. And people will use these terms interchangeably to mean roughly the same thing. And so the thing that I posted, that I retweeted, is about this group of people, right? I want to talk about just this group of people. I don't want to talk about group 1, who's not particularly ritualistic or patterned or avoidant. I don't want to talk about group 2, that 20% of the population that uses porn too frequently, to avoid, to not deal with relationship issues, attachment stuff, trauma, shame, sexuality, whatever it is. I'm talking about group number 3. So group number 3 that is commonly described as sex addicts, porn addicts, compulsive sexuality, problematic porn use, etc. This group of people, if you read research from like Pat Carnes, one of the first sex addiction gurus out there, or if you read a lot of the neuroimaging research that's been done, like from websites like Your Brain on Porn, which are propaganda sites, by the way. So propaganda sites have a narrative that's one size fits all. The reason I am not a propagandist, just so we're all clear, is because I'm trying to be specific and nuanced, and I'm not trying to say what you should or shouldn't do, just to be clear. I don't have a dog in the fight about how you see it, how you deal with it, or how you treat yourself, right? Because it's not my job as a professional, as a scientifically grounded professor, clinical psychologist, etc. So this group of people, the 1 to 5% of people who are using porn extremely problematically, right? So when I say extremely problematically, when we're talking about so-called porn addiction, compulsive sexuality, problematic pornography use, whatever it is, this group of people is obsessing about using pornography, often throughout the day, maybe not all day, but inconsistently throughout the day. They have lots of phobic feelings and beliefs about their sexuality, their sexual needs, their sexual interests, their sexual goals. They have shame about what they believe healthy sexuality is. Maybe it's religious shame, 9.999 times out of 10. And they have no real concept of healthy intimacy with regard to their emotional needs, their physical needs, and their spiritual needs. And so this group of people is a very unique group of people that is not heterogeneous, right? It's not a diverse group of people. It's usually a very stereotyped group of people. And so there's research from authors like Nicole Prouse, Josh Grubbs, that looks at religious shame in particular, and it appears to be one of the best predictors of compulsive pornography use. So compulsive means, in case everyone doesn't know, a lot of people don't understand the word compulsive because it's one of those words that's tossed around all day. But I want to make sure everyone understands what compulsive actually means, just so we're clear. So compulsions are not merely patterns of behavior. Compulsions are not merely repetitious behaviors, right? A compulsion is an irresistible urge that you feel like you have to act on, or else there will be intense, pervasive, severe distress or pain. So it's an irresistible urge with a terrifying fear of catastrophic pain or distress. And usually a compulsion stands in direct contrast to your conscious desires. And this is the important thing about a compulsion. In clinical psychology, a compulsion is usually an urge or a desire that relates in a behavior that you do that's in direct contrast to what your stated desires are, right? So if you're compulsively washing your hands, like in very severe OCD, where you have a germ phobia, etc., that causes this obsessive compulsive process to set in when you have severe OCD, you're washing your hands like 15 times an hour, and you're causing your hands to be dried out and bloody, right? So your conscious mind doesn't want you to wash your hands 15 times because your brain understands it's bad for you, but you have this irresistible urge to do something that is bad for you, right? And so when people talk about pornography use as an addiction versus pornography use as a compulsion, we start to see it's kind of an interesting thing, because all addictions include obsessiveness, compulsiveness, powerlessness, helplessness, a pathological relationship to intoxication emotionally, and attachment issues, all this stuff. But people with compulsive pornography use do not have all of those same hallmarks. They certainly have some obsessiveness. This top 1 to 5%, category 3, certainly has some obsessiveness. They're thinking about porn throughout the day. They can't wait to get off at night, etc. And they certainly will compulsively use it while they're doing it, but it's not the same thing for these people. There's not this attachment experience. They don't have like an emotional relationship to it, in the sense that they have these profound emotional beliefs about it, like you do when you have a substance addiction. And so what I want everyone to understand is that whatever label you use, I don't particularly care, other than if you're a professional, just be clear that the words you use have very crystal clear implications to the patients, stigmatizing and otherwise. So we have to be careful about the connotation of what we say as professionals. But for the regular consumers out there, it's statistically extremely rare to be in this top 1 to 5% group. That's a very rare group of people, right? Most people that problematically use pornography are in that 20% group. They're in that like somewhat patterned, somewhat repetitious, but not consistent, not obsessing all day, or compulsively using it all night, or whatever like that. That's very rare. It's a rare group of people, okay? So, compulsive pornography use is rare. It's not an addiction, in my professional opinion, because it doesn't share that same relational problem as substance addiction does, doesn't share many of the same neurobiological problems. In fact, the research shows that the neuro research shows your brain somewhat returns to normal rather quickly after you stop using pornography, or even if you spread it out more, which is different than, you can't like randomly intermittently use meth. Your brain stays hijacked, so to speak, consistently over time with meth, even up to a year after being sober from meth. So it's not the same thing in any way, shape, or form. What problematic compulsive pornography use is a huge problem. People are typically avoiding relationships. They typically have severe shame and attachment issues. And the beautiful thing is, at least according to the research I'm aware of, most people that are severely problematically using pornography can actually stop it and have a better relationship with sex by addressing whatever shame exists, especially religious shame. And if there's trauma, addressing that, and then the sexual compulsivity disappears and they become more integrated and they have a more healthy relationship with sex. Now, it's not like magical, like they do 6 months of good therapy and now they're perfectly fixed or something. It's a process that you get better at and better at over time. But if you actually do the work, you get better. It's not like addiction, where you're always getting better. You always go into meetings and all that stuff. It's not like AA. It's not a spiritual thing in the same way. It's just not. Sex is a spiritual thing, but pornography is not the same. So I hope that makes sense to everyone, because I want you to understand that it can certainly be a problem. It's a more rare problem than even substance addiction is, but it's not the same problem. And there's so much more to say, but I don't want to burn up too much time here talking about it. So I hope that makes sense to everyone. And if you have further questions, let me know so I can explain more, share more, so on and so forth. And if you haven't seen it already, I already created a video a long time ago that already addresses this. So please take a look at that whenever you get a chance. Okay? All right. What do we got here? We got some fun here to talk about. Oh, okay. Let's talk about Dr. James Davies. Okie dokie. I probably should have started with this before my chat about PSSD, but here we go. Okay. So our friend, Dr. James Davies, and his handle is at JDAVIES PhD. He is prone to posting things that, basically will cause a reaction from people who are, I think, reasonable. So here's what he said, I think, like 3 days ago. This is the quote. He said, "The medical model reframes the emotional fallout of wide human discontent at systems into individual defects and deviances. When single individuals submit to this program, the medical program, they get placating treatment," in quotes. Excuse me. "When masses come together and reject it, we get social change." So this is just absurd nonsense. So my response to it 3 days ago was, this is not true. This is propaganda. I am a very critical and precise and specific person. That's called skepticism. Being skeptical is not making wild overgeneralizations like all psychiatry does is take general life discontent and call it mental illness. That's fucking nonsense. So let's be perfectly clear. The medical model does not reframe, to use his words, the emotional fallout of wide human discontent at systems and turns it into individual defects and deviances. So let's be clear. You can hate the fact that poverty is a bitch and kills people and makes people more prone to trauma and dysfunction and addiction and not be mentally ill. I think all reasonable people go, yeah, poverty is bad. It's really, really bad for people. And if you come from a background of poverty, your chances of being, diagnosed with something are disproportionate to the, middle class population. Sure, that's different. But that's not the same thing as saying all poverty equals mental illness. That's stupid as shit. And let's also be clear that every psychiatrist that you will meet is not going to say, well, you're poor, so you must be mentally ill or something. That's absurd. Also, discontent at the systems. What systems? Are you talking about the federal government? Are you talking about the medical system, the healthcare system? Like, what system are you referring to, Dr. Davies? So you can always tell when these charlatans are propagandists because they use this drastically absurd and overgeneralized language like he does. It's so stupid. And let's be clear. I think modern psychiatry is really dumb. I think most practitioners are just no better than robots. I think they're not great. That being said, I know many great psychiatrists who care about clinical outcomes, who care about how they conceptualize a patient's suffering, and they care about precision medicine. They care about not over medicating, and they care about doing a good job and not keeping people sick forever. I've had the privilege of working with great psychiatrists who are like, yeah, you don't need to be on meds forever. Let's get you stable and move you on. That's great. I think that's the best use of psychiatry. But charlatans like this make it out like every psychiatrist is an evil hack who believes that all of your anger at society is just mental illness. That's crap. That's absolute bullshit. And Dr. Davies, I just don't know who you're talking to in the profession. I welcome you on my podcast at any time, Dr. Davies. Let's chat. Tell me about the psychiatrist you've met. Tell me about the clinical psychologist you've met. And I'll share with you. I just can't. I can't imagine the people you've met because I don't see these people. I'm in Los Angeles, which means that I have a very large sample of medical practitioners that I get to deal with living in a major metropolitan area. One of the biggest and richest cities on the fucking planet. I have met so few of those disgusting, evil people who are like, yeah, just medicate them, just sedate them. I met so few of those people. And like, it's LA. You would expect to see a lot of them. I see so few of them here. Now, I'm not saying that psychiatry is great and it's the best practice. I think it's one of the worst specialties and does the worst job and has the worst success rates. That being said, I've seen great examples of it. And so to speak in generalizations like Dr. Davies does should scare you all away from him because that's a propagandist. Darren, one of the other colleagues of mine who just chimed in here. Darren McGee said, you can't be a hero without a villain to defeat. So I'm not very interested in psychologizing people that I've never met because I don't know him. But there's a chance you're right, Dr. McGee. There is a real chance you're right that he would like to just be a hero, a keyboard warrior, as it were, as opposed to going out there and maybe helping people. Like, whatever you think about me and my Twitter behavior, which you're certainly welcome to think anything you want about me, I welcome any and all hate and any and all criticisms. Because I am abundantly crystal clear. I'm abundantly aware, crystal clear, that some of my behavior is off-putting. I fully understand that I am aversive to some people. And that's A-okay. Because I am not everyone's cup of tea. And I am allowed to be whatever I am, so long as I'm not actively trying to harm people. That is the clarity that everyone needs to have about the profession. We are allowed to be regular people and not be perfect. Because perfection is a really stupid fucking standard. It's not realistic for anybody. But to be clear, just so everyone's super clear, I am not a hack. I have a successful track record running rehabs, individual therapy, couples therapy. I have very good boundaries with patients, families, and couples, and I get things done consistently. So it's very clear. It's very clear, that no one can say anything about the actual work that I've done and the people that I have helped. That's not saying I'm perfect. I've certainly made lots of mistakes in my career, but I have a track record and a reputation. And so let's be very clear that when I talk about the nuances and complexities of being a clinician, of helping people with severe persistent mental illness, of being honest about what's working and not working in the system, I'm coming from 15 years of success. Not perfect success, not amazingness. I'm not grandiose. I'm realistic. And because I'm realistic, that's the thing you should trust. You should not trust people who speak in idealized ways like this guy, like Dr. Davies. So I want you all to be crystal clear that psychiatry is useful if it's done correctly, if it's used in a way that actually helps people. It's super clear that it can help people. But psychiatry does not take ordinary human suffering and call it depression. That's a bigger problem. The healthcare system is not great at actually identifying people who are actually sick. People are over-assessed. They're screened with measures they don't need to be screened with. People are over-treated. That certainly happens. But it's not this one-size-fits-all thing like Dr. Davies tells you. So please be aware, he is a propagandist. He is not a thoughtful critic and skeptic. There are a few of us out there that I believe are actual thoughtful critics and skeptics, including myself, Dr. What's his name? Let me see if I can pull up his name real quick. Other thoughtful, relatively more thoughtful critics like Nick Tabor, like what's his name? Grant H. Brenner, MD, on Twitter. Another very thoughtful, open, overt, very verbal skeptic is Dr. Sanil Rege at Sanilrege. He's great. At Doc, Docgrawich, Doc Grawich. Matt is great. He's a skeptic for sure. I think he's great. Camilo Ortiz. Many of my colleagues on the podcast right now are skeptics. Dr. Awais Aftab, I'm sorry if I'm not saying your name correctly, at AWAISAFTAB. These are all the skeptics I know who are very critical of the profession, who have a nuanced and specific perspective that's not this all or nothing, it's all good, it's all bad. All good, all bad propaganda. Those people are not skeptics. Those are charlatans dressed up with medical professionals. And, he put his degree in his title, right? So that's a problem. So please ignore the propagandists because they're not going to tell you the truth. They're going to tell you what they want you to hear, right? I'm not invested in whether or not you take meds. I'm not invested in whether or not you seek out therapy. My general hope is if you need support from a mental health professional, you're very clear about what you believe you need and how to be skeptical and critical and precise and specific, because that's generally what people need when they're trying to get help. That's it. That's all I care about. And if you need help, please make sure you're getting the best possible help. Please be ultra demanding from your professionals. Please be explicit about everything that you think you need. That's all I care about. I don't care about making $1 billion as a clinician or some shit like that. That's all stupid. The people who care about the profession succeeding, the people who care about it dying, those are hacks and charlatans. Those are people who are gears in the machine, and they're disgusting. And that's most people because most people are cowards. That ain't me. That ain't some of these people I just mentioned. So big props to all the people here chatting and the people I referenced here. Jardom chimed in. Glad to see you here, by the way. Olanzapine ruined my sex drive, slowly coming off it. Well, yeah, I've heard that from some people as well. Some people take antipsychotics like olanzapine or Zyprexa, and it does hurt their sex drive. So please be wary of all psychiatric medications because all of them have adverse effects, and all of them can be managed in many ways. Sometimes they need serious intervention to be managed. But please take extra good care of yourself and please communicate very consistently and clearly with your provider if you're taking any medication so that you can get the best possible treatment. You deserve the best possible treatment. You do not deserve mediocre treatment ever. If you're paying money, if you're using your insurance or whatever you're doing, you're burning your time, your cash, or your insurance to get help. Demand everything you can out of the providers you have. Get everything you deserve out of those providers and be realistic about the fact that none of us are perfect and none of us can cure you or fix things for you. That's not what we can do. That's not our job. That's not our skills. That's not who we are. Okay. What else do we got? Let's get back to the topics du jour here. All right, let's talk about harm reduction. So my buddy Jonathan Cogburn, a man I love dearly, who is just awesome, like many of the people here chatting, like Career Flex and Darren McGee, etc., put out a post that I really think is worth discussing and maybe even discussing in a part 2 next week. Okay. So here we go. So 4 days ago, Jonathan Cogburn, and his handle is at Systemic Texism, TEXISM. He put out not a podcast. He has a Substack. You should follow his Substack for sure. But he put out a post 4 days ago, and this is what it said. Let's check in on the private therapist groups on other platforms and see how they're, what in the fifth circle of hell is this, he said. So, and I quote, should we give drug paraphernalia and Narcan to a child with self-harming behavior and suicidal ideation and encourage them to use safely? So he posted a screenshot of, I believe, some private practice forum, Reddit, I don't know what it is. So I'm going to read this screenshot to you so you understand what we're talking about. So this is an anonymous post on some therapist supporting therapist subreddit or something. And here's what it said. Here's what the person said. The person said, I know of a therapist doing, in quotes, harm reduction strategies when working with a teen with active suicidal ideation and self-harm behaviors. This therapist has offered to take methods, as in items for intended self-harm, from the client and store them in their office, rather than telling the client's parents or reporting to a crisis team, as a way to increase trust and maintain confidentiality. On numerous occasions, they have met with the client at the office without parent knowledge to take the items, and may meet for hours at a time with the patient, doing crisis response, ensuring safety with the client. I would love to hear thoughts, ethical considerations, concerns that come to mind regarding this. Thanks so much. So let's talk about why my friend Jonathan probably had the reaction, what in the fifth circle of hell? So let's be clear. Ethics. So ethics is one of those gray things, unfortunately, because every case is different and there's a lot we can't know just from like a Facebook post or whatever, right? So there may be, I'm going to say this very clearly so everyone can understand and not sue me or whatever. There may be dozens of details I don't know about this post that I just read. And without those details, I may not have a very crystal clear, accurate, thoughtful opinion. So I'm going to try to be thoughtful to the extent that I can, so everyone can walk through this. If you're working with teens, it's very important, unless the parents are outright abusive, it's very important for the parents to at least have an understanding of what you're doing clinically with them. There are exceptions, like outright physical abuse, outright emotional abuse, sexual assault by a parent, serious pervasive trauma or neglect at home, like serious addiction in the home. There are many more dangerous or unethical things happening in the home that might make it less helpful to have the parents involved, to be clear. However, most of the time, in most situations, even if the parents themselves are sick or whatever, it's still helpful for them to be involved and know what you're doing with them as a professional. Okay, I hope that's clear. Point number one. So the fact that this clinician in this picture is saying nothing to the parents, basically, seems rather unethical. Okay? Number two, harm reduction. So harm reduction is an entirely large topic that in today's podcast, I won't have enough time. But let me just say a couple of like high-level things about harm reduction. So, number one, harm reduction is not about getting people off drugs. So if you have the expectation that harm reduction is going to help with the addiction crisis, you're stupid. Harm reduction is just about reducing the spread of disease and things like that. So clean needles and needle exchanges are just about making sure if you have dirty needles full of HIV or hepatitis or whatever it is, you're not sharing those with people, which to me seems like a public good. I think decreasing the prevalence of HIV and hepatitis is a good thing for everybody, but I could be crazy. So on that score, harm reduction is useful. On the score of actually helping people who are very, very, very unwell, probably not so useful. So that's that. Another thing you can say about harm reduction is that the people that are implementing harm reduction are probably overly compassionate, and they probably need to get some help. They're probably not the healthiest, most boundaried people, but maybe I'm wrong. I don't know. So that's another thing. But that's a generalization. I could be wrong about that. Number three, harm reduction, if it's done correctly, can help people not die. Whatever is described right here in this post is not harm reduction. That's just coddling. That's not harm reduction. So dear professionals and dear patients alike, please hear this. If you have a patient who is self-harming, and if you have a patient who has severe suicidal ideation, where they have a plan and the means to end their lives and the intent to end their lives, then you should not be doing hours and hours of crisis intervention and avoiding telling the people that are protecting them, like their family that they live with. Everyone should be aware of the crisis you're dealing with. Mandatory. You have a duty to warn per California state law, at least where I live in California, unfortunately. You have a duty to warn. And if you're not warning people, you're breaking the law, right? And so I'm not a huge fan of the law. I'm not a huge fan of California, but I don't want people to die. I'm one of those common sense people, I think, where it's like, let's not let people die because you think you're so smart and special you can rescue the patient. That's narcissism. So what I believe I'm seeing in this post is this narcissistic clinician. Again, I could be missing dozens of details, so caveat, but this so-called compassionate therapist who's basically spending hours with their patient and trying to rescue them during a suicidal crisis, that is not good clinical work. That's enabling, that's enmeshment, that's narcissism. That is not helping the person. That's hiding and having a special relationship with the teenager. Now, I've worked with adolescents, and I know how hard it is sometimes, because sometimes the parents are sicker than the kid, right? I've seen that many times in my career. So maybe telling the parents is bad, like I said earlier. But generally, if you're doing this over and over and over again, where you have to like save the patient's life, that's about you rescuing and saving the patient. That's not about good ethics and good boundaries. So when Jonathan says, what in the fifth circle of hell? He's correct. So please, your therapist is not your savior. Your therapist isn't here to rescue you. Your therapist is not an ER doctor. Your therapist is not an ER nurse. Your therapist is not an EMT. Your therapist is not God. Your therapist is not a life coach or a guru. Your therapist does not have all the answers. Your therapist is not supposed to be the only person you tell about your suffering. Let me say that one more time in case you didn't hear it. Your therapist is not supposed to be the only person you tell about your suffering. In fact, if your therapist has any common sense, they will tell you, they will encourage you to have healthier relationships with people where you can talk to them about what you're going through and get the support you need from them. So the fact that in this example of this post, this clinician's trying to save this patient in secrecy and in privacy, that's not good. That's a very bad sign. That person is probably breaking their ethics code, if not breaking their local laws. So what in the fifth circle of hell is exactly correct. That is not good ethical behavior from what I can see, from what I can tell, just so we're clear. So you should never, as a therapist, as a person who is not a physician, we should never be touching needles. We should be never touching drug paraphernalia. As clinicians, we should never be handling any of these things. In fact, if patients do have harmful means that can end their lives with, like guns, knives, and drugs, it should never be our responsibility to handle those things. It says nowhere in our ethics code, it says nowhere in the APA ethics code that we are to take people's guns, drugs, and knives from them, ever. We should be encouraging people to take those things and give them to someone they trust, and in rare cases, surrender them to law enforcement, right? Like, we should not be touching them ourselves. That's a God complex thing. In 15 years of being in the industry, I've never taken someone's drugs from them. And I've worked in rehabs almost my entire life. I have never taken a gun from somebody. I've never taken weapons from people. I have thrown some things away after they've been voluntarily surrendered to me without me asking. But I've never asked people for their paraphernalia or their drugs or their weapons. I have never. Never. I have stored them in like a company safe at a rehab or whatever, but I have never taken them from people. That's narcissism, and I'm playing God and shit. And that's not what you pay your clinicians for, just so we're clear. So, Jardam says, without sounding ungrateful, I've gotten a lot more out of my personal trainer than I have my psychologist. And that's actually not surprising, by the way, because what I would say is a little tangent from what I was just talking about. Personal trainers give you specific concrete feedback about improving your form, your posture, and whatever you're working on so that you get tangible results very quickly, comparatively speaking. Whereas like working through some of the things that you work through In therapy, it might take, months or years before you see tangible results where your life is drastically better. So I think if you need help with your fitness, personal trainers are great, for sure. So back to this topic about ethics. Dear patients everywhere, your therapist is not your savior. Your therapist is not your guru. Your therapist, of whatever degree, a psychiatrist, a psychologist, an LMFT, LPCC, LCSW, your therapist is not the person saving your life. If your therapist talks about you like they are saving your life, that's a serious problem. So that's very unethical, whatever we just saw and read, etc., in this post from Jonathan. So that's wildly concerning. So please be on the lookout for that. So I think we're going to just wrap up on one more quick one. Hola, Phil. Glad you're here. Yeah, let's save it. I'll save it for next week. I was going to talk about the word should, but should I think is something we should discuss. We should discuss next week. Okay. Well, you know what, folks? It's a pleasure to see you all here. I'm sorry that I got a little bit of a quasi later start, like a couple minutes late today. I want everyone to understand. I hope you all genuinely understand that my goal here with the UnShrink Me podcast is just to make sure everyone has the best possible chance of getting the information they need to have the best mental health possible when they're seeking therapy, seeking psychiatry, treatment, rehab, whatever. So this podcast is just dedicated to you, the consumers, the public. Please take good care of yourselves. And please demand as much as possible out of the professionals you're paying money and time to be with, because it's healthcare. It's your health. It's your life. Your life matters. And we are not supposed to be casually treating people. This is not a casual thing, just so we're clear. And as always, I hope that you like and share and subscribe and you let other people know about this podcast, because I really would like to bring as many people in to get the information they need and perspective that might help them. Because I believe that it's hard. I believe that it's really hard for people to get the help they need and to feel supported. And I genuinely believe that if you're seeking out therapy from even a mediocre clinician, you can get something from it. I don't think you have to be an expert or a really great therapist. You can be a really good intern. You can be brand new and be good at things. So you don't have to be a perfect therapist to help people, and you don't have to be a perfect patient. So please take extra good care of yourselves. Share this with anyone who you think needs it. Thank you to everyone, Darren and Jardom and Phil and Career Flex. Thank you for being here and chatting with me and chiming in and sharing your perspectives and your experiences. It's very appreciated. It's appreciated in ways that maybe you don't fully know, because it really makes this more fun and more interesting. And I think it's helpful for people to hear real people talking, And as always, I like to end with a joke. And so without further delay, here's this Saturday's joke. So I once worked with a patient who had a horrific phobia of clowns. I'm sure there's a word for it, but I don't know it off the top of my head. Anyways, so this person had a horrific phobia of clowns. And so when you have phobias, fears, usually you do exposure therapy. And one of the exposures you do is called graduated exposure, where you progressively expose them to more and more severely intense phobic objects, ideas, and images. And so, we did the usual beginning exposures where we looked at pictures of clowns and watched videos of clowns. And then in like our fifth or sixth session, we were watching a movie, I think it was called It, with a clown in it. And we're watching some of the scarier scenes of it. And the patient was just having a really hard time and freaking out and panicking. And that's normal. And we're trying to, use the regulating skills. But in the process of watching the movie and freaking out and panicking, he accidentally knocked over a lamp. And when he knocked over the lamp, I asked him, like, how are you feeling? What happened? What's going on with you? Just checking in. And he said, I feel like a real bozo. All right. I hope you have a great rest of your weekend, and I'll see you next weekend. Take good care of yourself. Treat yourself well. Treat other people well. Be